before we get started, I just wanted to point out a couple things. I have no conflicts of interest. We're not going to be talking about any commercial products. I did represent a distributor who was involved in the opioid litigation a couple years ago. I don't currently, and the issues we're going to be talking about really don't involve any of those kinds of issues that are at issue in those cases. And separately, I wanted to mention that a lot of my discussion is directed at physicians, but it's important that physicians aren't the only prescribers of controlled substances. So dentists are also very heavy prescribers of controlled substances. There are other non-physician healthcare providers. And this really applies to everybody, although the focus is on physicians, in part because we have some ethical rules that are specifically applicable to physicians. I'll also mention that there's one slide that I wasn't able to get in on the version that you guys have here that we're going to be displaying, but when the slides are circulated, there's an additional slide that you'll see. So the first question really is, if we're going to talk about overprescription, what does that mean? What is overprescription? Because obviously the person writing the prescription doesn't consider it overprescription. So, what are the standards that we're using here? And so I kind of have outlined from other materials and from cases just things that I think we can probably agree would represent overprescription by today's standards. One is prescribing opioids as a first-line medication for pain relief in situations where other effective options are available. The second is prescribing opioid medications in high-risk clinical situations in the absence of a compelling medical need. And so what do I mean by high-risk situations? Well, you may or may not be familiar with the morphine equivalent terminology, which kind of tells you, that translates a lot of different opioid products into morphine equivalents, and talks about the fact that if you're taking more than 90 a day on a chronic basis, that's kind of excessive. And so it's not to say that that's per se problematic, but it is viewed as a high-risk situation. And similarly, prescribing opioids really at any level, along with benzodiazepines, is also high risk because about a third of the overdose deaths are related to a combination of those two drugs put together. There's another category, which is prescribing opioid medications in appropriate doses for appropriate indications, but in excessive quantities. And we'll talk about that in a minute. But for example, for knee and hip implant surgery, people often give an appropriate dose, but they give 90 pills because there's no reimbursement for them to come back for a follow-up visit. And in fact, the data show that people only use about 15 on average. And of course, this is not intended to be an exhaustive list. This is kind of the main things, but there are other situations, for example, like there are forms of fentanyl that are spray forms that are viewed as appropriate for intractable cancer, but really are not appropriate for a number of other situations. So I wanted to briefly mention, there's an American Medical Association Code of Ethics 9.6.6, and it says, in keeping with physicians' ethical responsibility to hold the patient's interest as paramount in their role as prescribers and dispensers of drugs and devices, physicians should prescribe drugs, devices, and other treatments based solely on medical considerations, patient need, and reasonable expectations of effectiveness for the particular patient. And then it goes on to describe other circumstances. But I think if we're looking at this as an ethical question, that's sort of an important backdrop for us to keep in mind. So first off, let's kind of flip this around and say, so what are appropriate or ethical physician goals in prescribing opioid medications? And I'm focusing, by the way, on opioid medications. The title is controlled substances, but opioids have overwhelmingly, been the substance of interest, although I understand that methamphetamine and other controlled substances in some venues are very concerning. But I think at the moment this has been kind of the focus of concern. So first of all, providing patients with effective pain relief still remains an important clinical objective, and one that we have to not lose sight of. In other words, this whole pain is a fifth vital sign, which was kind of part of the rubric of medicine probably when most of us, at least in my age range, grew up, or at least in the last 20 years, has almost come to be a dirty word. And there are slides showing that the opioid epidemic is due to or resulting from this whole pain as a fifth vital sign. Pain as a fifth vital sign was really intended as a compassionate measure. It was, physicians intended to do their best to relieve patients' pain, and it got a lot of traction from a lot of different vicinities. And there are people that say, well, it really came from the pharmaceutical industry. It may have, but it got picked up by CMS, and it got to the point where reimbursement, you couldn't have reimbursement if a patient didn't sign off on the fact that their pain was adequately relieved. So it really became integrated into the medical system, and it wasn't anything nefarious. It was originally intended to provide good care to patients and to ensure their pain was relieved. You may recognize some of these. This is kind of the 5 vital signs with kind of the pain scale of happy to sad faces, the pain assessment tool. All these things are things that were in common usage. So we have to not lose sight of the fact that pain relief is an important goal. We just need to make sure we're trying to achieve it in the most appropriate way. The second related subject is attempting to make evidence-based decisions about opioid prescriptions, particularly in the context of chronic pain in non-terminally ill patients. And why do I carve that out? Well, terminally ill patients are, in a sense, a category of their own. Nobody is really concerned about addiction because the likelihood is they're going to need quantities of pain relief that may end up resulting in addiction. And it also is less applicable to acute situations where you're prescribing it for a very short period of time. The people who run into trouble are generally people who are prescribed it on a chronic basis. And so what are the things that you can do as a prescriber? Well, one is, if you do have a patient that's on long-term high-dose opioid medication, is consider weaning. There's a lot of pain management physicians that I've talked to who have very successfully taken patients on very large amounts of opioids and successfully weaned them down. It has to be an intentional strategy. It's not something that's done easily, but it is something that's achievable. You may not be able to get people off it altogether, but you can often greatly reduce the amount that they're taking. Second is employing multimodal pain management strategies. Other non-pharmacological strategies for pain relief, which is a little beyond the scope of what we're talking about today, can be extremely effective. And if they're used supplementally or complementarily with opioid medications, you can often use lower doses. And then the final thing, which we were just talking about yesterday, is acceptance of some amount of pain as being okay is also important. The idea that we have to completely eliminate, every ounce of pain, if you will, is a little bit overbearing. And there are times where pain can even be, in some respects, a helpful thing. So having the objective of complete elimination of pain may be a little unrealistic and may not be the target that we should be shooting for. As everybody probably knows, the CDC came out with guidelines in 2016 for the treatment of chronic pain. And as part of those guidelines, these were primarily intended for primary care physicians who were treating adult patients with chronic pain. Again, this wasn't intended to apply for acute pain. It wasn't intended to apply to cancer patients or palliative or end-of-life care patients. They talked about how non-pharmacological and non-opioid pharmacologic therapy are preferred for chronic pain. And that when opioids are started, clinicians should prescribe the lowest effective dose, and that they should carefully assess the evidence of individual risks and benefits when increasing a dose beyond 50 morphine equivalents per day. CDC was responding to, and as you probably know, 2011 was sort of the banner year, which saw a peak in prescribing, and at the time, a peak in overdose deaths. They also said that clinicians should use caution when prescribing any opioids at any dosage, in excess of 50 milligrams, or I'm sorry, in excess of 90 morphine equivalents, and that physicians should carefully review the patient's history of controlled substances, and we're going to talk about prescription monitoring databases in a second, and that physicians should use urine testing before starting opioid therapy and consider urine testing either during or at least on an annual basis while therapy is going on, and also avoid, as I said, prescribing opioids with benzodiazepines. Sometimes this also happens because another physician is prescribing. You may have a pain physician or orthopedic physician who's prescribing pain medications, a primary care physician who's prescribing benzodiazepines. As I assume most people have heard of these, but starting about 10 years ago, most states implemented something called a prescription drug monitoring program. And these are statewide databases that gather information from pharmacies on prescriptions that are dispensed to individual patients of controlled substances. And the typical users of these databases are prescribers, pharmacists, law enforcement agencies such as the DEA or state equivalents of the DEA, medical licensing boards, and other kind of licensing boards. And the way these things work is, as a physician, and it varies, as all these things do, from state to state, but probably I think the majority of programs require a physician, before dispensing a prescription for a controlled substance, to check with the prescription monitoring database. And what's the idea behind this? The idea is that sometimes patients who are addicted have drug-seeking behavior, and they go to a number of different physicians, all with the same story. And if physicians don't have a high index of suspicion that this patient is a drug seeker, they may kind of take the story at face value and go ahead and prescribe it. And so this is a tool that allows a physician to know what other controlled substances this particular patient was prescribed sort of in the recent several months. They also allow law enforcement agencies and medical boards to monitor aberrant prescribing practices on the part of physicians. And I expect our last speaker, the director, blanking, can't remember how to pronounce his name properly, but I'm sure that their board uses this tool to evaluate prescriptions. The other thing with prescription drug monitoring, I'm sorry, let's see. The other thing is that the evidence about whether these have had an impact kind of varies. One of the problems is that not all states have state-to-state data sharing. So where I live, Virginia is right next to Maryland, is right next to DC, and unless these three venues are all sharing information and allowing physicians who are licensed in each venue to know whether a patient had a prescription in another venue, you can see that it sort of dies on the vine and it's not really effective. So that's one of the issues, and there's great variability also in the extent to which physicians are required to report this or pharmacists are required to report this, but it does put physicians and pharmacists on notice to some extent. And I think it's been a positive development. I mean, in some respects, physicians don't like it necessarily because it takes an extra 2 or 3 minutes of their time to go check on something, and the yield is probably relatively low. On the other hand, this is an effective way to identify patients who may be gaming the system and maybe can tell a good story with a straight face, and the physician wouldn't otherwise know better. So finally, last couple things are prescribing appropriate amounts and avoiding excesses. And so what do I mean by that? Well, this is an article that was published by Hannon in the Journal of Arthroplasty, and it kind of gives you some key facts about it. It says that after hip or knee surgeries, they did this study with 304 opioid-naive patients, meaning they'd never had opioids before. And they were randomized to either receive 30 or 95 milligram oxycodone pills at the time of discharge. And the reason they picked those dosages is because that's a fairly standard dosage formulation post-surgery for hip and knee replacement. And then what they did is they looked at basically how much these people used. And in the first 30 days after discharge, the median number of unused pills was 15 in the group that got 30 pills and 73 in the group that got 90 pills, meaning that the 30 group used about 15 pills on average and the 90 group used 17 pills on average, assuming I'm doing my math right here. Importantly, there was no difference in pain scores within the first 30 days and in the patient-reported outcome scores 6 weeks post-operatively. So why is that important? Why do we care about that? Well, we care about it because one of the issues is where does this oversupply of opioid prescription medications come from? And one of the places it comes from is this kind of situation where I have a hip replacement, I take 15 pills, I had 90, I don't want to waste the money, and in case I need it for a rainy day, I put the bottle in my medicine cabinet, should I need it again for some reason. And what happens? My teenage son gets a hold of it, or something like that happens. That's where this oversupply comes from in large part. Was the doctor wrong? No, this is kind of a standard prescription, but it's awareness of these kinds of situations and the awareness that they don't really, patients don't really need this large amount of medication that kind of sort of has to educate and inform our prescribing practices as we go forward. The last piece is thoughtful monitoring of patients. I mean, the truth of the matter is that if patients are on chronic medications, they're gonna develop tolerance. They're gonna at times have a need for more. That's not a character flaw. It's something that's inherent to the medication. And there are times where we have to be thoughtful about our monitoring of patients. We have to be aggressive even about referring patients for treatment, whether the treatment is rehabilitation, whether it's counseling. We have to consider that our prescription has put this person in a situation where they may not be able to fend for themselves. They may not have the tools they need, to get out of the situation that they're in right now. So where are we, and what have been the results of these efforts, of these education efforts, of the CDC guidelines, of implementing these prescription drug monitoring programs and so forth? Where does this leave us? Well, if we go back to, and I put this slide up here because it's an older slide, and this kind of depicts the trend in opioid prescribing kind of up to about 8 or 9 years ago. And you see there was just kind of a gradual increase that was pretty substantial, over the course of, the years from, let's say, 2002 to 2012. And there's separately an observation that, and these years don't correspond exactly, but there is also, an increase in opioid overdose deaths. And of course, people kind of made the logical correlation that, more opioid prescriptions probably led to more opioid deaths, and that's not an unreasonable inference. And that's largely what led to many of these efforts on the part of the CDC, on the part of prescription drug monitoring programs in the states, and so forth. So what's been happening more recently? Well, the good news is that if you look at this just in terms of volume, the volume of opioid prescribing has gone down very considerably. And this graph kind of depicts it from, thank you, Tony, from the peak at 2011, gradually decreasing down to 2020. And so what we've seen is a 60% decrease in total prescription opioid use since 2011, a 40% decline in the total number of opioid prescriptions, and the number of prescriptions being different from the first one deals with sort of total volume in terms of overall total opioid use. The second one is a prescription-only thing. And the greatest decline, which is a good thing, has been in states that previously had the highest per capita use. And also, these same states are the ones that had the highest overdose deaths. But what's the bad news? I mean, you say it's good news that we're getting the prescriptions down, I guess. What's the bad news? And the bad news is, first of all, there have been a lot of unintended consequences. And this is an article about a petition to the CDC to clarify some of their guidelines because of some of the unintended consequences. And so this article talks about the fact that among its recommendations are that opioids should rarely be used as a first option for chronic pain, that clinicians must carefully weigh the risks and benefits of maintaining opioids in patients already on them, and that establishing or transferring patients should be offered the opportunity to reevaluate their continued use. Okay, I don't know that that's necessarily a problem, but here's where the problem does come in, which is within a year of the guideline publication, meaning by 2017, there was a widespread misapplication of some of the guideline recommendations. Notably, many doctors and regulators were incorrectly suggesting that this 90 morphine equivalent was kind of a de facto daily dose limit, when in fact that wasn't what it was intended to be. And clinicians prescribing higher doses and pharmacists dispensing them and patients taking them came under tremendous scrutiny. I have a friend of mine who's a pain physician who actually historically testified fairly frequently on behalf of the government in cases in which the DEA was pursuing inappropriate prescription cases. And he told me that he was rather shocked in recent years where he found himself being recruited to testify in cases, and he's kind of waving the flag going, wait a minute, this isn't inappropriate, this is this is perfectly fine. And so there's a lot more aggressiveness on the part of law enforcement, on the part of medical boards, on the part of hospital supervisory committees and so forth, where they're just sort of clamping down on it, and the burden of proof really shifts to the physician or the healthcare provider to justify what they're doing. Why is that a bad thing? Well, it's a bad thing because in some respects, patients who need opioid medications, and there are patients who need opioid medications, may not be getting the relief they need because doctors may be gun shy about prescribing them when it's appropriate to prescribe them. Patients with chronic pain who are stable and arguably benefiting from long-term opioids face draconian and often rapidly involuntary dose reductions. Often alternative pain care options are not offered, not covered by insurers, or not accessible. Others are pushed to undergo addiction treatment or invasive procedures regardless of whether they're clinically appropriate. So that's the negative side of what happened. Separately, and this is probably from my vantage point, I guess the greatest concern, this is something I actually, while I was preparing the slides last week, I saw this article on CNN that reporting that the U.S. Reaches record high of more than 96,000 drug overdose deaths in a 12-month period, CDC data shows. And reported drug overdose deaths in the United States hit a new high. According to this data, in that 12-month period, the U.S. saw 96,779 reported drug overdose deaths, an increase of 29.6 from March 2020 to March 2022. Now, this is not, this is a statistic that I also think separately you need to kind of process in context. And so, like as Dr. Wall was talking about, this also happens to intersect with the COVID pandemic. And the COVID pandemic necessarily included people being more isolated, a whole host of new medical problems, and probably increased utilization. We don't really have good data on it yet, but increased utilization by patients of these kinds of things. But it's concerning. And so, here's the trend in opioid overdose deaths. And what we see is that it's mostly in heroin. And when it says synthetic opioids other than methadone, what that means is it means a fentanyl, a synthetic fentanyl, not medical grade fentanyl. So there's this total disconnect between the trends in opioid prescription and opioid overdose deaths, which kind of calls into question the relationship between these two things. And opioid deaths are increasing related to heroin and illicitly manufactured synthetic fentanyl. And what it does, there's this widely accepted gateway hypothesis, which is that people who die from heroin overdoses started on prescription opioids. And there's actually a surprisingly small amount of data that suggests there's this progression between the two. There's actually a paper by Muhari, which is at SAMHSA, which is a government agency that does research on substance abuse. And their data was that only 3.6% of non-medical prescription opioid users ever used heroin within 5 years. And so, and by non-medical, that doesn't mean, so if you're using, let's say a doctor prescribes you for pain 4 times a day, under the way they do the statistics, if you take it 5 times a day, that's misuse, but it's medical use because you're taking it for a medical purpose. Non-medical use means you're basically taking it to get high or for what would historically be called abuse. So, the fact that such a small number of people who abuse prescription opioids lead to heroin use, and that heroin use is what's driving the opioid death rate, we have to take a serious look at this. So what does this mean and not mean? Quickly, it doesn't mean that we should stop making efforts to ensure that healthcare providers are prescribing appropriately. It doesn't mean that the problem of overprescribing has been solved, but what it does mean is that we can't expect controlling the opioid overprescribing is going to solve the opioid crisis, and it doesn't mean that we need. It does mean we need new initiatives to ensure that things are combated. So, last slide. The path forward is that healthcare providers have an ethical obligation to continue to provide appropriate relief. Prescribing decisions should be evidence-based. We should continue to use databases to identify drug-seeking behavior, have education about avoidance of high-risk prescriptions, avoidance of prescriptions of excessive amounts, refer patients who need it for appropriate treatment, and have an appreciation of the increased use of heroin and fentanyl as associated overdoses as a public health crisis, not necessarily related to the overprescription of opioid medications.